Thank you for having me. I appreciate that. And yes, my accent is quite evident. I'll start with some of the pleasantry jokes if you would like. In the South, we have some conditions that patients are experiencing that we're not seeing around the rest of the country, such as buffet-itis, salad allergies, biscuit poisoning. So if you guys see some of this in your area, call us and we can give you some ideas how we treat those folks. Yes, I did went to Auburn. I graduated from Auburn and I talked my way into the University of Alabama Medical School for anatomy and cadaver dissection, which is quite ironic that I went to Auburn and I had to go to Alabama to get an education. So there's my joke for Auburn for the day. Thank you very much for having us. I'd like to introduce you to MiMedx. And who is MiMedx? We're based out of Marietta, Georgia. We're the world's largest processor of amniotic tissue. So we have a team of collection agents, and I'll get into how we derive these products. If you look at it, MiMedx does process all 4 placental components. We offer a amniotic sac derivative, an amniotic fluid, the umbilical cord, and the placental disc is processed in various brand names here. I want to clarify that we do not espouse or state that we offer stem cells in these products. What we offer is a collection of proteins. Upwards of 65% of all amniotic tissue that is processed and implanted today or administered comes through MiMedx, and that's through the ophthalmic, dental, the diabetic foot ulcer space, venous leg ulcer, and various other specialties such as urology, colorectal, and in my department, orthopedics. We pride ourselves on science. Our CEO was a former Air Force pilot and engineer. He lost a son to SIDS early in his career, and he developed the first Holter monitor and brought a SIDS monitor to market, the first one based on his experience. He espouses credibility in science. Currently, we have over 40 scientific articles that are peer-reviewed, published in various levels of evidence. A majority of those in the level 1 prospective class come in the diabetic foot ulcer or the venous leg ulcer or prostatectomy. We do have a prospective study in anti-fibrosis in spine that was done with Dr. Subak and the Virginia Spine Institute, what we'll get into in just a second. But you see here, what we want to talk about today is called AmnioFix. This is the amniotic sac. In natural anatomy, the sac comes in 2 layers. MiMedx offers both of those, the amnion and the chorion layer, together. We separate these two, and then they're cleansed, brought back together, and dehydrated, and that's where the dehacum comes from. What we are able to claim today based on the regulatory status of the product is that amniotic tissue has demonstrated over 300 articles over the past 110 or 15 years its ability to modulate inflammation through paracrine signaling. It does result in a reduction of scar tissue, and for you, we'll discuss how that applies. And it also, these growth factors or proteins, cytokines, chemokines, that's really what we're offering, is the ability to process this tissue and retain this collection of proteins. So MiMedx does not alter this, concentrate it, or otherwise change it. It's just cleaning it so that you don't pass on from one patient to another the things that you don't want to, and we retain the more native and natural structure of the tissue. This is regulated under the 361 human cell tissue pathway. That is for the membrane, the actual sac, the umbilical cord product that we have, and the placental disc products. If you'll notice, there's a BLA pathway here for biologics license application. Currently, MiMedx is in phase 3 with FDA for an Achilles tendonitis, plantar fasciitis, and osteoarthritis indication for the knee. And that is taking the amniotic membrane, we micronize that into a powder or particulate so that you could administer that in a closed fashion versus in an operative situation with a membrane. We expect to have those indications within the next 18 months, and that is fully disclosed to the street. We are a publicly traded company. We're very excited to take a human tissue product now and offer the ability to have indications, and that will drive reimbursement in the clinic so that you can offer this signaling not only to a patient in the clinic, but you'll have an option for the OR as well. So where do we get this? I get asked this as I travel around the country a good bit. There's a lot of miseducation in the marketplace today with these products. I can only imagine the amount of folks that have entered your office or approached you in the OR claiming stem cells. It is a hot button. Regeneration is a term that's a hot button term. What I want to describe to you today is that we take products that consenting mothers donate to us with inside the continental United States. They're approached about 30 days out. If they decide to donate, a recovery technician that is an employee of MiMedx in consultation with a hospital, we have 9 of these around the country. The donation is received at time of cesarean delivery. We do not accept any vaginal deliveries. It is then the Chorion process, and Chorion is a name we come from. It means pure amnion. We're attempting to offer you a natural product. It is contained, sent back to the company. It's tested against the World Health Organization transplant standards. If it passes quarantine, then the tissues move into production, and then we wind up with a product here. Okay. So this is kind of the Chorion process. To give you an idea of what we do with it, it's a series of gentle cleanses and washes. The 2 layers are separated, dehydrated. It is a terminally sterilized product. After terminal sterilization, you're left with a product that I'll show some histology in a second. It has a 5-year shelf life in the office and in the hospital. No freezers, no cryopreservation. It's a simple pull it off the shelf, open the sterile pack, and use it. If you decide not to, it goes back on the shelf for storage, okay? And that can be applied in the clinic as well. We've had over 1 million grafts implanted or administered with 0 reported adverse events attributed to the tissue. So we're very proud of our safety profile. The real risk is the money involved if you choose to utilize it. We do not say that this will affect every single patient, but paracrine signaling has the ability to communicate with the patient. This is the sheet graft that you see here. Due to Photoshop, this is very clean and sterile looking. These products do come out, they're human tissue, so if you open up one of these and it's got a mild discoloration to it, that's very natural due to human anatomy. This is just for print and marketing purposes. When you have folks that are going to approach you in this regenerative space, they're going to be selling you one of these 3 type pillars. One's going to be living cells. Some may sell you just an extracellular matrix-based product that has xenographic history to it, or they're just selling proteins. What I'd like to show you today that we offer 2 of those pillars. Here's the extracellular matrix of the amnion and chorion layer. The chorion layer is roughly 4 to 5 times thicker than the amnion. Very simply put, these are fuel tanks. The amount of protein distribution in each, the chorion has a much more significant contribution of these proteins than does the amnion. A majority, and principal majority of these amniotic tissue companies on the market today only offer a single layer amnion, not the dual layer. MiMedx is the only one that has the patent for laminating 2 layers currently. So what do we say about this product? And with all the benchtop preclinical testing and clinical studies that we have, we can demonstrate ability of these collection of proteins to communicate with a patient's body. So if this touches the dura, this touches a tendon, muscle, or fascia, it stimulates a response from the patient's own body. And what we can show, and we offer every bit of this. If you want the bulk of our data, I will send you every study that we have. We have it written in a book form, so all of this is offered to you if you would like it, and we will be more than happy to share it with you, all of our research. That when this is implanted in a patient's body, it causes a few things. The migration of the patient's own pluripotent stem cells out of circulation in the local area to migrate towards the graft site. At that point in time, these proteins communicate with cells such as mesenchymal cells, adipose-derived stem cells, or hematopoietic stem cells to proliferate in numbers, and then ultimately these cells start producing their own growth factors, and it continues this cycle of modulating inflammation, reductions in scar tissue due to the barrier properties and the signaling properties, and ultimately it just excites the area in which this is implanted. So the regeneration term, are we describing that this regrows perfect structures? No. What we're describing is that this gives the body a chance to heal more properly than it could on its own, especially with advanced age and other comorbidities, which we've studied in patients such as that as well. As of 2 months ago, we were able to describe to you exactly which proteins that we have in this tissue. We just completed a 600 protein panel, and we're able now to show that there's over 500 of these proteins in each graft that we have or we offer to you. And they're all described here. We can describe to you the volumes that they're present as well as the which ones they are. Okay. So what we say is this kind of resets the inflammation phase if you have a chronic patient, and that's more for the diabetic foot ulcer, market in chronic inflammation, but you guys are more in acute situations. What we want to show you here is the blue is the amnion layer, the red is the chorion layer, and this is the relative contribution of proteins or cytokines or chemokines in each layer. We're also able to describe to you that when you implant this into a patient within the first 24 hours, there's a collection of these cytokines and chemokines that are weakly bound. They elute immediately within the first 24 hours. So there's this established pro-inflammatory response to the patient. And then ultimately what our benchtop and preclinical testing shows that over the next 28 days, these other proteins that are bound in the matrix are released as the body remodels the tissue and accepts it and regrows into it. There's a large angiogenic potential with some of these proteins. We've completed some ischemic models and murine models as well, and describing the vascularity in the diabetic foot ulcers as well. These patients, we've got some level 1 prospective evidence in the diabetic foot ulcer arena that these tissues that are growing on the plantar portion of the foot are more like plantar skin, and they're not showing the same reulceration rates as when utilizing a more extracellular matrix-based product. So it is stimulating a revascularization and the ability to call the patient's own stem cells to the site of injection or implantation of the graft. And we're very comfortable with that, to the point that MiMedx has trademarked, this term called a stem cell magnet. And I understand that's a small bit trivial, but we're looking for ways to communicate with patients that they understand what it is that has been implanted in them, or in the clinic for, say, facet injections. What is exactly this product and what is it doing in my body? The last thing we want as a company is for patients to think that they are receiving a stem cell therapy. And you're going to be told that a lot. You're going to hear a lot of noise in the market about the amniotic tissue. I have an amniotic tissue as a rep, and this has stem cells in it. Be mindful and just ask for their data, because there is a lot of folks toting these tissues and describing to you things that they have not preclinically or clinically validated. And FDA has taken notice. Before Thanksgiving, FDA has now basically set some guidelines on that 361 pathway, and they're going to narrow the ability of companies or reps or others to come out and what language they can use or claim. Okay. This is Dr. Subak and the Virginia Spine Institute conducted a prospective study. They have a protocol that they dictate. They're going to go back in and remove hardware once fusion is confirmed. And forgive me, I am not a spine expert, but this is the group that for us made a lot of sense. If they're going in to remove the hardware to begin with, then it makes sense to put this membrane in with the expectation that the dissection, we could see how much fibrosis occurred or did not. And in these 4 out of these 5 patients, they saw significant reductions in fibrosis. We even have videos of the dissection where they're describing the anatomy looks more normal and their dissection is much easier to get down to the level of fusion to remove the hardware. This was an initial look at orthopedics for MiMedx. MiMedx is now actively moving into the research space in orthopedics. We're into injections into OA spaces. We're into this anti-fibrosis. We're actively now testing this with disc material to see what to expect with disc injections. Also facet injections, and something I'm working on personally is open orthopedic trauma, granulation tissue. These proteins are demonstrating a massive ability to communicate regardless of where they're administered and then the response that's elicited, and we're actively looking at that now. And it's showing tremendous potential. These are just some case examples here, not nearly to the level of Dr. Santos and what he just went over, but this is from the VSI study, and it's showing the membrane. It is dehydrated. It is very easy and tactically to use with your gloves on. It's not slimy. It is dry. If there's sufficient blood in the area, the graft will absorb it. 8 to 10 minutes before it really starts to get a little wet, so you have plenty of time using your instrumentation or your gloves to administer the product and put it in. We do advocate, though, that you complete all suction procedures or washout procedures, because the graft, once it gets bloody, can be difficult to see, and we would hate to see a graft wind up in the suction canister. Okay. And then looking here at dysphagia for ACDFs, this is that anti-scar or reductions in fibrosis that we're really seeing in the orthopedic community. Hand surgeons, I've been working with the University of Louisville, the Kleinert and Coots group for hands. Tampa General is another site that I'm working very closely with. as well as looking at open trauma. Now, with that, I will stop there. I know I have just a few minutes, but I wanted to open up the floor if anyone has any questions for us as a MiMedx, as a company, or that I may can answer for you.
Well, thank you for opening our eyes.
Thank you. Thank you.
By the way, do you know what this is back there? This is a mountain. This is Mount Rainier.
It's quite large, and I noticed that flying in, and I've kept my eye on it a couple of times. We don't have those in the South.
Yeah, good. I was worried that you didn't know what this was. This is real. Yeah. So, so this is obviously, let me take the lead here, amazing field, and we're obviously very much in need of having novel approaches towards regenerating tissues, both in cord injuries. You saw 2 patients today, but also in the multitudes of degenerative fields, and the spine with its 56 motion segments is a prime target. How can we be assured that your product doesn't just do 2 things, which you mentioned, which is create new scar tissue? The fibroblast migration was on the top of your list. If you go back to that great new, like I think the 3rd or 4th slide was very, very good. And how do we know that this is not, or this is a true angioproliferative kind of a substance? So how do we know this is not just another way to create more scar?
Absolutely. We have done some benchtop testing on human dermal fibroblasts. We do demonstrate an ability to proliferate those cells, as well as it has an ability to turn those off. So with the modulation of inflammation through the 3 phases of healing, we show an excitement of cells, proliferation, and then a down regulation at the proper time, the way the body utilizes these proteins. What we don't know is which proteins are pulled by the body in the circumstance of which it's implanted. So this collection of proteins is we're offering it to the body, and then it seems to be that the body is accepting the signaling that it's asking for based on the circumstance. But we're seeing a definite reduction in scar tissue formation.
Is Dr. Glenn still here? Glenn Davids? Oh, here, yeah. So what about, good morning, Glenn. Sorry, you were incognito there with your black outfit there. What are your thoughts in terms of applying this? If a patient comes today with a bad facet joint or a dark disc, what would you tell this patient when they ask the usual stem cell question, which I will have today, and I think Bob in clinic will both have probably multiple patients today who will ask for some stem cells. So what are your thoughts in terms of putting this into a human disc or into a facet joint or something like that?
Well, there's a huge potential with a product like this. There's a huge potential with a product like this. Looking at going forward with disc regeneration and facet degeneration, which products going forward are going to be giving us results, though. A product like this, it has a huge amount of potential, though, in terms of helping to generate the disc and then facet joints. But as we looked at, is there going forward enough studies going forward, and this product, they're developing studies in regards to disc regeneration, facet regeneration, and we'll have to wait and see. There are already products out there that are more stem cell and claim to be more stem cell products that have had some regenerative outcomes already, and this product in particular has a huge amount of potential, though.
What confuses me is, again, I'm again the eternal skeptic. So I see the chance for fibroblast invasion and angiogenesis, but then this paper confused me totally, because again, why would the epidural space not be more scarred? What would the properties of this substance be to basically create less scar when this is, again, the first effect of the protein concoction that you promote? So how can you explain this?
So it can be the anti-reductions or the limitations of scar tissue can be attributed to the barrier functions of the product. So if you have a sheet membrane that dissects 2 planes of tissue and it just holds those 2 apart for a certain period of time, you can decrease the amount of adhesions that subsequently follow. What we don't know is what contribution that the proteins attribute to the reductions in scar tissue, and which part just mechanically does the barrier limit those structures from adhesing together.
And what is the barrier made of again?
It's extracellular matrix, mainly collagen, laminins, proteoglycans, things of that nature. We can go back. I think we have it on here. Here. There we go. And that's the histology. Now, the cellular structures in these are retained, so it has full cells intact, but they're non-viable. And what we describe that to is attributed to our Chorion process, that we can cleanse the tissue without stripping the tissue and busting these cells, if you will, and they retain some of these growth factors.
So again, the current FDA clearance is especially clear for wound management, is that right?
They actually, FDA regulates this for homologous use, which is a term that most people, and even FDA says, is a little ambiguous. You can use this from head to toe, any fashion that you see fit. The areas that we stay away from is claiming to regrow organs or regrow bone in a bone void. Those require PMA approvals, like 11 years, really, to get that type of indication. But these are protein signals that you're offering to the body to communicate with the patient's own body.
So if I follow you, I could put this into my bone grafts today and hope that it attracts additional ingrowth in my whatever autograft or whatever I put into the post-solid gutter. Is that right?
It's a very interesting thought, and it's one thing that we are actively researching now is combining these proteins in other products, such as fusion products. We're just not to the point that we're allowed by FDA to make any claims on that. Is that happening? Yes. I just can't tell you credibly what to expect.
Because again, one of the main things that we learned about BNP is that it probably really works as a hyper-inflammatory substance, right, Jeff? What are your thoughts on a product like this?
So it's interesting. I don't know if you're familiar with AF Cell, Robin Young. So I actually invested early on in a product like this, and early on, the promotion of a product like this was actually for fusion, which requires this, immunologic response, this inflammatory response. But now you're telling me that it's almost anti-inflammatory.
There's a massive pro-inflammatory response. And the inflammation is something that is gaining a lot of traction in how important is inflammation and what levels. What we're saying is this doesn't necessarily anti-inflammatory, it modulates the inflammatory phase to not allow it to get out of balance, to drive itself towards a chronic more condition versus this keeps us in the acute phase and progresses through the proliferative phase.
I think you guys are taking this in a very thoughtful manner, because in reality there still really are not very good clinical studies behind this. And I think you have to be really careful, because when you're talking about like pluripotent cells, or the pluripotent potential for these stem cells to become anything within that lineage, whether it be bone, cartilage, discs, fibrocartilaginous tissue, you have to be very careful with respect to the signaling that occurs between these cells. And you mentioned that these cells are not viable. So really, I think that utilizing this as a barrier is a good entry to that, but not going into like making any claims like this is going to be a stem cell that can regenerate, disc
Correct.
tissue or help sort of fortify like fusions. I think that's very smart from a sort of a industry commercialization perspective.
Yeah, and to give you an idea, the growth of MiMedx, and we see the potential of this. I mean, we went from a few $1 million in 2010 to over 330 this year. We went from 50 employees to almost 1,000, and we're projecting even more growth. We realize there's a future here, and there's no need to go out and make wild claims that are unfounded. What I'm offering or describing to you today is we're at the initial phase of learning and discovering what to expect this in an orthopedic situation. We've administered this in a various amount of specialties. We are approached by, you name it, wanting research and data, folks coming to us, share your research about these proteins and what to expect. And you're exactly right. We do not espouse that these cells in this will turn into anything. What we're saying is they're more like little warehouses, and we retain the proteins in those based on how we cleanse it. But yes, we're very careful.
I had an understanding that some of the first applications of these were in ophthalmologic.
That's correct. Single layer amnion today, yes.
And that's mostly to reduce scar tissue, right? Because
Yes.
in those cases, it really, the outcomes are based on scarring. So that was really the first push of these kind of amniotic products. And you've seen other applications in sort of other orthopedic.
Yes. So to give you the wide gamut, ophthalmic and dental space is just a single layer amnion due to the anatomy, and that's just the single layer. Now the dual layer is in the foot and ankle space. We've been in the general surgery space, plastic space, you name it. We've had over 1 million of these implanted. It's just a lot of this stuff is anecdotal, and we're now at the point where we're challenged to provide level 1 evidence and clinical evidence. But I'll be honest with you, it's a challenge with the money. These are quite expensive, and the entire human body is kind of our playground at this point, but discovering what to expect in each application is going to take time. Yep.
So far in the studies that have taken place, it seems like a lot of it's been done in diabetic foot ulcers. Has there been excess amount of scarring occurring, and have you guys documented any reduction in scarring, or how are you guys doing that?
So how we quantify that is long-term follow-ups. So we did an initial prospective study of diabetic foot ulcers compared to standard of care. How do they heal? How quickly do they heal? And then we followed them for the next 12 months, because these diabetic foot ulcers have a large reulceration rate at the site of the original lesion. We're showing now massive reductions in reulcerization, excuse me, that's my Auburn, that 26 letters in the alphabet get tough sometimes. But we're showing that the tissue that grows back is more native and then mechanically acts more normal, so it doesn't want to pull apart and open, which scar tissue wants to do. So that's where they originally started. We just launched a large VLU trial, and we're going to seek a BLA indication in VLUs and DFUs as well. So you'll see us continue to push away from 361, which is a more unregulated pathway. You'll see us continue to move towards BLA type products that have FDA indications backing, and that will drive reimbursement and adoption clinically as well.
How expensive is one of those vials of those little granules or those membranes?
That's a good question. May I ask you what you think it'll be?
I have absolutely no idea. I mean, it could be thousands.
That's the first question. Everybody wants to step back because there are some very expensive products in the clinic for administering, let's just say, for a facet joint. We offer a product that's under $500 to you, and then you can decide then where to go with the patient. There are currently 5 states in the country. Blue Cross Blue Shield is reimbursing for this injection currently, so we're expecting more and more payers to adopt this. But it's for under $500, you get a product that has these proteins. What we can say, for instance, in a facet injection with preclinical or benchtop testing, is that this can induce a production of synovial fluid by synoviocytes. Now that is preclinical, that is benchtop. I'm not saying we've done that in a human yet, but that is the area that we're looking at, is the ability to stimulate the body to produce its own healthy synovial fluid. And that's where we're getting pain relief for patients in injections.
All right, so you could do this tomorrow, right? With some FDA approval without specific indications. I learned something new there. So I want to thank you very much for coming all the way out here. Real pleasure to have you here, and thanks for opening our eyes. And thank you, PacWest, for supporting this trip.
Thank you very much. I appreciate your time.